I'm going to change the topic just a little bit by talking about health literacy as an essential component of the Quadruple Aim. As a matter of fact, I think I'll make the statement to say that in the absence of a health literate population, achieving the Quadruple Aim is not possible. So I think we'll try to move on that topic to start with. So if we think about in the delivery of health care, we've heard this morning and we hear it time and time again, that communication is a key ingredient. My discussion this morning was really made that much easier by the presentation of the commission paper. Indeed, many of the supportive statements in that paper are part of what we've discussed here in the past, part of my presentations in the past, and also will be incorporated into some of the PowerPoints that you see this morning. The important focus on the quality and patient safety domains of the Quadruple Aim is really what I'm going to discuss. So I'm going to take the journey that has brought us here today, and indeed it is usually the journey and not the destination that's the joy of what we do, and so that's the purpose of my discussion. We'll go forward and try to make the point that if we focus on new ideas, if we focus on innovation and disruptive technology, innovation that creates a new value equation, and that's going to be health literacy, disrupting the current thinking and value networks. So let's think about it in that way, really disruptive technology to achieve our goal. I think that's what Einstein was trying to say. I think that's what Machiavelli was trying to say. We need to change. And I think also it's what William James was trying to say in 1892. And move to disruptive thinking supported by science and supported by patient experience, and avoid old habits. I think that's what we would like to accomplish today. So what is health literacy? We know that the current design of the healthcare system requires patients and families, we've heard it today, to possess and demonstrate multiple skills, including understanding and giving consent, interacting with health professionals, and applying health information to different situations in a variety of life events. So the important part of what I think health literacy is, and thank you, Lila, for this, is that we have a definition, but health literacy really occurs when system demands and complexities are aligned with individual skills and abilities. We know the definition, but unless we align the demands and the complexity with the individual skills and abilities, I don't think we really can achieve a true health literate population. So why is health literacy important? I like to think about the quality enterprise in this country, beginning for the 21st century with the IOMs, the then IOMs, the Era's Human, building a safer health system back in 2000, and then the IOMs crossing the quality chasm in the 21st century, 2001. They really recommended systematic identification of priority areas for quality improvement. The committee was charged with generating a list of 15 to 20 candidate areas. And let's remember that because that's important. In a population, I think maybe the only population study of health literacy skills conducted to date, the Department of Education National Assessment of Adult Literacy documented that only 12% of United States adults, 12% of the United States adults are proficient enough in health literacy to understand and use health information effectively. They may fail to understand critically important warnings on the label of over-the-counter medications, as we just heard, find it difficult to define a medical term, form a complex document, let alone negotiate the payer system and trying to understand, insurance. So that alone is quite important. So let's look at the priority areas of national action. I think it's clear that quality is considered to be a system's property. It didn't focus on improving treatments through biomedical research or technological innovation. It focused on ways to improve the delivery of treatments. And once again, to align system demands and priorities with individual skills and capabilities, the true definition of health literacy. It identified priority areas that presented the greatest opportunity. And if we look at those priority areas, you will see that they are very familiar to us: acute care, preventive care, palliative care, chronic care. But they were cross-cutting system interventions, system demands that require the presence of a health literate population, self-management, care coordination, all requiring health literacy, patient and family engagement, all requiring health literacy. So beyond a disease approach, all is not possible in the absence of a health literate population. If we look at how care is delivered currently, the cycle of crisis care is too familiar to us. And it occurs in very many ambulatory settings, very many ambulatory settings. The sick patient comes in seeking medical help. The staff at the physician's office asks the patient to complete very complex, very confusing forms. The doctor explains, or the healthcare team explains conditions and treatment plan using medical jargon, and on and on and on. And what happens? The patient takes medication incorrectly, doesn't follow up on appointments because it hasn't been effectively communicated to the patient. The patient condition gets worse, goes back to the ED, and once again, sick patient seeking medical help. So that's what we refer to as the cycle of crisis care. We would much prefer a health literate patient experience where the scheduler reminds the patient about coming to the office, the staff does things in a health literate way, the physician or medical team does things in a health literate way. And I think the team function within the office is extremely important. And the discharge instructions, nurse giving the patient a really health literate, simple handout, and the staff at the physician's office following up. And then you have a patient who's well managed, does not go back to the ED, is not rehospitalized, and indeed a health literate experience. So about the time that we were referring to with the IOM report, recent federal policy initiatives, including the Affordable Care Act of 2010, the Department of HHS National Action Plan to Improve Health Literacy, and the Plain Writing Act of 2010 really brought health literacy to a tipping point. That is really poised to make the transition from the margins to the mainstream, and made it a priority to become health literate. And if that happened, the nation's health literacy can be advanced to the point at which it will play a major role in improving health care and health for all. And that was in Health Affairs 2012, only 5 years ago. And I do believe that we picked up from them really, as I said, a tipping point. So the National Action Plan to Improve Health Literacy had two principles. All people have the right to health information that helps them make informed decisions. It's a right. Health services should be delivered in ways that are understandable, lead to health, longevity, and good quality of life, and principles of better care and improving the health of the population and the community. And of course, the Plain Writing Act of 2010 required federal agencies to write documents clearly so that the public can understand and use them. I'll leave that to your judgment as to whether that actually occurred. And now there really is a national quality strategy. And believe it or not, the national quality strategy was introduced in about 2011. The Affordable Care Act required the Secretary of HHS, and that was Secretary Sebelius at that time, to establish a national strategy that will do what? Achieve the triple aim. Sound familiar? Improve quality of care, improve population health, and affordable care. That was exactly the focus of the National Quality Strategy. And indeed, the National Quality Strategy was an iterative process. It was transparent. It was consultative, consensus-building process. Actually, the National Priorities Partnership of the National Quality Forum wrote the National Quality Strategy for then Secretary Sebelius, I know that process because I happened to chair that committee at that particular time, and so I'm very familiar with the iterative process that was undertaken to create a national quality strategy. And it remains. It's been updated on a regular basis. So the national quality strategy was to concurrently pursue the triple aim, clearly the purpose of a national quality strategy. And I must say that Don Berwick was HHS just before. He was at CMS just before this was accomplished, and he really championed the triple aim at that particular time. So all requiring the cross-cutting interventions that I mentioned before. So once again, there are 3 aims and 6 priorities of the National Quality Strategy. Those priorities are health and well-being, prevention and treatment of leading causes of mortality, and we started with congestive heart failure being a major problem in the United States, person and family-centered care, patient safety, effective communication, and care coordination. If I knew enough about health literacy when we wrote that first National Quality Strategy, I would have changed effective communication to health literacy. But we do it now. Effective communication and care coordination and affordable care. So who's at risk? We know men greater than women, Black and Native Americans, white greater than white and Asian. We've had that discussion around the table about improving the life of those who are in need. Hispanics had the lowest skills among minorities, and persons 65 and older had the lowest overall health literacy. There is a website, NIFL, that will enable you to, for your specific region, to give you some information about health literacy in your state, in your county, or town. You can just go to the National Institute for Literacy, the NIFL website, and you'll be able to get some information that may help you in terms of deciding upon resources for your particular area. So, and we also know that patients with, and we've heard it today, and there's no harm in repeating it, patients with limited health literacy have lower quality communication, confusion regarding medical terminology, insufficient time to express concerns, they fail to receive clear explanation, less likely than others to use preventive services, and we heard some of that with the paper. And what does that translate to? It translates to poor outcomes, and it also translates to higher mortality. And when you begin to discuss social determinants of health associated with health literacy, you see there are some areas where mortality and your expectation for life may be 20 years less if you're living in certain areas in the United States, particularly in and around Baltimore happens to be an area of concern, but others around the country, around Baltimore. Your life expectancy may be considerably less living in those communities because of the reasons I've tried to explain. So let's think a little bit about what we really can do about this. Think about building a learning health system. I know we've discussed this to some degree around the roundtable, to better inform regarding health literate practices and achieve the quadruple aim. Build a learning health system around the concept of health literacy. It'll enable an environment of rapid cycle learning, you won't have to worry about that 17-year period, and knowledge dissemination in which health literate research is continuously translated into practice, and practice the care experience into research, which is really a proven approach for driving improvement that does not necessarily occur naturally in healthcare today. So let's build this learning health system. This is the definition as applied by the National Academy. And let's build it around our concerns about health literacy. So in simpler language, the health system is going digital. 50% now, 80% by 2019. If each care provider, patient, and researcher used his or her data only for immediate needs, we are undershooting the potential. It's really the principle of quality improvement, dashboard and data. If comparable data are shared, we can learn and improve, and the key is to figure this out, how to do it routinely, and I'm saying building a learning health system around the concept of health literacy will enable us to do that more efficiently, for sure. And then, of course, there are principles that have been applied and we've discussed, but I think need to be articulated and stressed. And one has to do with universal precautions. And this is very similar to the universal precautions we use in infection control in the hospital, of course. Everybody is thought to come in with a bug, and therefore hand washing becomes critical, and other areas of universal precautions around infection becomes critical. So we have to structure the delivery of care as if everyone may have limited health literacy. Everyone has limited health literacy, because you can't tell by looking. Higher literacy skills do not necessarily mean understanding when you're talking about health literacy. Health literacy is a state, not a trait, and everyone benefits from clear communication, something we all learned early on in our training. And if you look at what universal precautions will produce, and again, ARC has been a champion of this from the very beginning, so we thank you much for your work there, Cindy. If you have a prepared, proactive, health-literate healthcare team. And again, I use the word team because I don't mean physician. I mean team. And you have an informed, health-literate, activated patient and family. You have productive interactions and improved outcomes. It's really as simple as that. It requires no more science than we just have on this slide. And then once again, ARC is responsible for this. It was developed for ARC by the University of North Carolina, I believe, Cindy. And it's something we've looked at, many times around the roundtable. It's been updated. If you go to the ARC website, it's been updated. But the Universal Precautions Toolkit really provided us with tools, a path to improvement, and the appendices at that time, which has been updated, had over resources such as sample forms, PowerPoint presentations, and worksheets. And once again, very useful. The toolkit standouts included tips for communicating clearly, the teach-back method, we've discussed that already, the brown bag medication review, I love that, asking patients to bring their medications to the office, particularly the over-the-counter medications, encourage questions, make action plans, use health education material effectively, and as most important is get patient feedback. None of this happens in the absence of putting the patient first and remembering you need patient feedback for your next steps. Now, smartly, the Joint Commission weighed in, and not only the Joint Commission, but other accrediting organizations weighed in to make the comment that the safety of patients cannot be assured without mitigating the negative effects of low health literacy and ineffective communication on patient care. I know the NCQA, sitting on their committee, their CPM committee, really focuses a lot on communication and health literacy. The Joint Commission coming out with this statement was very helpful because of the Joint Commission survey process. And we also know that, of course, our 10 attributes, which were referenced earlier, are critical to really creating a health-literate organization. And I'm going to make the point more so that not only make it easier for people to navigate, understand, and use information and services to take care of their health, but I think the paper that was written most recently and published in August of 2017 in Academic Affairs on organizational professionalism really ties in to health-literate organizations. You really can't have a health-literate organization in the absence of having a charter on organizational professionalism. The attributes of I just want to refer to two attributes because I think it's critical if we're really going to think about having health-literate organizations and at the same time an organization that has a charter for professionalism. It has to have that leadership that makes health literacy integral to its mission, to its structure and operations. Not only making clear and effective communication a priority, but has to allocate fiscal and human resources to make that happen. You can't make it happen in the absence of putting resources to the effort. And of course, the second attribute is critically important in addition, and that is integrating it into planning, evaluation, measures, safety, and quality improvement. I think health literacy and communication has to be measured to be certain that it is happening in the organization. It has to be integral to your quality improvement program, to your performance improvement program, and to the efforts on patient safety. And once again, you measure the success in achieving health literacy attributes, and you identify areas for quality and performance improvement. Now, that organizational professional charter that I referenced earlier was published in Academic Medicine in August of 2017. There are 4 domains in that charter. They are patient partnership, organizational culture, community partnership, and operations and business practices. All of them require communication in a health literate manner, every one. And so when we talk about a charter of organizational professionalism, included in that charter has to be a health literate organization. Now, the paper that we heard today demonstrated published outcomes, and many of them are on this particular list. But they all demonstrate there is clear improvement if you have a health literate organization. Congestive heart failure self-management program, reducing hospitalization rates by 35%. I mean, that's a considerable number. The diabetes self-management program, one of the biggest epidemics in our country, in patients with limited literacy, achieved success by improving the literacy rate, 42% versus 15% in managing their diabetic patients. We heard about the re-engineering discharge, thanks to a member of our roundtable from Boston University Hospital, Michael. Very helpful in better understanding how to reduce rehospitalization. Medication counseling, improving skills, the concern about higher colon cancer screening rates, and also nice to hear that AHIP, the American Hospital Insurance Plan, have really undertaken explicit health literacy initiatives to improve outcomes in patients. This comes from one of our payors who's sitting around the room right now, Steve Rush in United. This is the estimated effect of health literacy on selected health outcomes, controlling for education, controlling for income, race, and language. And once again, you can really see significant reductions when you go to use health literacy as part of your everyday activities. Avoidable ED visit rate, avoidable hospitalization rate, medication adherence rate, and this is payer data, readmission rate, and ED visit rate, all of which, by the way, in 2018, 17, 19, and 20, will translate into a greater income for the institutions participating in these activities. So once again, although the CFO is not particularly part of my conversation, they always seem to end up somewhere because one of the necessities in any institution is revenue. So what are the conclusions? Let's just look at some of the conclusions. Best care and improved population health requires adherence to health literate principles. Cross-cutting interventions to achieve the quality goals of the IOM, previously mentioned, now the National Academy, and the National Quality Strategy requires bilateral health literate communication. You have to align the system demands and the system complexities to individual skills and capabilities. I think that's a key part of any definition of health literacy. The efficiency in the delivery of health care, particularly in the treatment of chronic disease, requires health literate skills. And as you know, we have multiple epidemics in this country related to chronic disease, whether it's diabetes, whether it's obesity, whether it's heart disease. It is an epidemic. And if we're going to address this appropriately, we must be innovative. We must build a learning health system around health literacy and create what we want to create. Enhancing patient and physician satisfaction. And let me change that. Enhancing patient and the healthcare team satisfaction and mutual trust, improved adherence, and diminished burnout. And we know the rate of burnout now amongst healthcare team members requires optimum communication skills. So it's communication and health literacy that will enhance patient, healthcare team satisfaction, and really impact the high rate of burnout we have in healthcare providers in this country. So I leave you with that as the set of conclusions. I hope the journey was a pleasant one, because I think it's got us to where we are today. And I'll open the floor to any questions for myself or Catherine. Catherine, why don't you go back up here?